London, 1858. Human waste routinely poured into the Thames River. Cholera outbreaks were routine, and the stench drove lawmakers away from Parliament. And yet, before penicillin was invented, even before bacteria were identified, life expectancy started rising. How was this possible? And the answer was not in miracle drugs. It was cleaning up the sewers to prevent disease in the first place. And today, instead of helping people live meaningful stress-free lives, we measure your blood pressure in a 15-minute visit and we call it prevention. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut, and I run my own medical practice. This video is the story of how public health moved from sewers to stethoscopes, and why doctors now shoulder blame for problems that infrastructure used to prevent. We'll trace two landmark moments in American history. The first is the sanitary revolution that saved lives, and the second is the germ theory and Flexner reforms that professionalized medicine. This origin story also explains America's healthcare paradox: world-class medical infrastructure for medical treatment and a weak public health system that routinely leaves people behind. Let's dive in. In the 19th century, cities across Europe and North America underwent rapid industrialization, resulting in a massive population shift from the countryside to cities. This urban density overwhelmed the existing infrastructure for housing, water supply, and waste disposal in these cities. And this lack of infrastructure created a fertile breeding ground for disease, which led to diseases such as cholera, typhoid, and tuberculosis taking hold in these communities. Edwin Chadwick, a British lawyer and social reformer in 1852 report, argued that all of the most common and dangerous diseases may almost always be traced to filth, overcrowding, and the absence of drainage and pure water. Chadwick's work launched the sanitary reform movement, which framed health as a civic outcome and not a moral failing. The focus was not on treating sick individuals with medicines, but on re-engineering the urban landscape to prevent disease from occurring in the first place. This dominant view led to sweeping public health investments in sewers, waterworks, and waste removal across London, New York, Boston, and other cities. These investments resulted in a dramatic reduction in cholera, tuberculosis, and other infectious diseases, which led to an increase in life expectancy. Sanitary reform wasn't voluntary. It took government a tremendous amount of power, including taxes, regulation, and construction, literally in our ancestors' backyard, to move human waste out of neighborhoods and to bring clean water in to keep people from dying from these diseases. The flowchart on the side shows the interaction of the different determinants of health and some of the high-level interactions that were taken by the governments to improve life expectancy. And today, we're still debating about the government's abuse of power during the COVID-19 pandemic. But again, that's a story for somebody else to tell. And by the way, if you did not watch or read my series on the determinants of health, which are the real drivers of disease in the population, you can find them on PCP Lens website or in my YouTube playlist. This table shows a list of diseases that public health interventions were very effective in either reducing or eliminating from America. You can find the table in a written version of the article on pcplens.com. The success of public health is a paradox. It is invisible and hard to measure, as the disease never happens and people live happily. There is a lot of political talk today about finding the root cause of diseases and fixing it. That starts with building public health infrastructure to improve the determinants of health, which are the root causes of chronic disease. All right, let's move on to the next chapter of medical history. In the latter half of the 19th century, French chemist Louis Pasteur and German physician Robert Koch shattered the miasma theory that disease is caused by foul air and established the germ theory of disease. This theory stated that diseases are caused by bacteria. This revolution had massive implications. It shifted causality from the environment to the individual. It gave doctors and labs a new epistemic authority, and it laid the groundwork for clinical interventions like vaccinations, antisepsis, and antibiotics. This new scientific understanding shifted the focus of medicine from re-engineering cities to diagnosing and treating individual pathogen-related diseases in patients. The germ theory of disease then set the stage for the rise of what's called the scientific physician. In 19th century, American medical education was an unregulated, chaotic mess. The American Medical Association, which was founded in 1847, had long sought to elevate the doctor profession by establishing uniform standards. In 1904, it tried to do this by forming the Council of Medical Education, which would inspect and rate medical schools. However, it had no authority to enforce any of these standards, so this effort went nowhere. As the 20th century began, the American medical education landscape remained deeply fragmented. While elite universities like Johns Hopkins were pioneering a new rigorous standard based on German research university model, they were vastly outnumbered by a chaotic marketplace for for-profit schools that required little more than the ability to pay tuition. In 1910, the Carnegie Foundation published Abraham Flexner's Medical Education in the United States and Canada, which was a sweeping indictment of the substandard profit-driven medical schools. This Flexner Report proposed closing substandard schools, requiring a minimum 2-year college degree before medical school admission, standardized curriculum which required 2 years of basic science plus 2 years of hands-on clinical training, which is pretty much followed today, and the university integration that was staffed with full-time faculty. The Flexner Report was a cultural transformation for medical education in America. Its effect essentially was that medicine is not a trade to be learned, but a profession to be entered. Backed by the AMA and philanthropic organizations such as Rockefeller and Carnegie Foundations, the Flexner Report succeeded in reshaping American medicine. While the Flexner Report dramatically improved the quality of medical training, it did have unintended consequences. It centralized medical legitimacy to elite academic institutions. It marginalized alternative forms of healing, including community-based care. And most importantly, it de-emphasized public health. As sociologist Paul Starr put it, the sovereignty of scientific medicine in the 20th century rested not on the clinical results alone, but on control of the cultural authority to define health and illness. Physicians emerged from the Flexner era as the professional class most closely associated with health, even though the largest gains in life expectancy still came from improvements in infrastructure, nutrition, and housing. The Flexnerian revolution fundamentally altered the landscape of American health by creating a deep and lasting schism between two distinct domains, clinical medicine and public health. This divided our health system into two specialties, the physician heroes of biomedical medicine who saved your life when you became sick, and the invisible public health officials who worked tirelessly in the background trying to keep you healthy. To be fair, this specialization initially led to immense progress in both fields. However, it also institutionalized a division in funding, training, and political focus, which over time shifted the focus away from societal health towards individualized medicine. Also, since the Flexnerian medical curriculum was organized around basic sciences, discrete organ systems, and specific disease pathologies, it inherently favored medical specialization. Payment reforms later cemented this, with significantly higher payment for specialists compared to their generalist colleagues such as primary care, family medicine, and pediatrics. This then set the stage for the decline for primary care. As primary care declined, more people developed complications due to lack of good primary care services. And paradoxically, this then led to an increased demand for even more specialists. And the cycle kept repeating, and now it's hard to find good primary care in America. So how did the medical profession achieve the power to create such a system? Paul Starr, in his prize-winning work, The Social Transformation of American Medicine, argues that professions achieve power by establishing authority, which in turn depends on legitimacy, that is the public's acceptance of the profession's claims to superior knowledge and competence, and dependence, which is the public's reliance on the profession's unique skills and services. Authority can be further separated into social authority, which is defined as the power to command and direct action, and cultural authority, that is the power to construct reality by defining what is normal and what is deviant. For example, what is healthy and what is a disease. The rise of the medical profession was a concerted effort to build both forms of authority, social and cultural. This over time created the necessary conditions for the phenomenon sociologists call medicalization, the process by which normal human conditions and social problems come to be defined and treated as medical illnesses. And not only do we pay the price for medicalization of normal behavior such as shyness, grief, pre-diabetes, pre-hypertension, etc., but also a cultural acceptance that healthcare is a contract between the individual patient and their doctor, and that it is not a social contract between people living in the same community. And this ideology of focusing on individual health is why our system has consistently neglected housing, wages, and other social determinants of health, all the while continuing to fund expensive medical services. And the system is so bad now that we are shoving these social problems into clinical medicine under value-based care. The implementation of the Flexner Report came with huge trade-offs. America has the world's best and most technologically advanced care. but at the same time we perform really poorly on public health measures and prevention of chronic disease. Now, history is never linear and always follows a complex arc. For example, my simplistic narrative ignores the vast gains from vaccines, which required innovation and collaboration between both the biomedical model and the public health infrastructure. This slide shows several vaccine-preventable diseases and public health mechanisms that were put in place in the last centuries to improve health outcomes. And while I've been glorifying public health also has its blind spots. The efforts of public health can and are unequally distributed. For example, housing reforms and zoning changes often follow racial and socioeconomic patterns, leading to people living longer in some zip codes as compared to others. But at the end of the day, it's also true that the real problem with the explosion of chronic disease is because we let the public systems rot. And now that healthcare budgets have blown up, we handed the cleanup to doctors, especially primary care. The doctors who have no tools, no time, but are being blamed for not preventing disease in the population. You can find a written version with references to the material and audio podcast version on PCPLens.com. If you like this video, please sign up on PCPLens.com so that you don't miss the next episode when it's published. Thank you for watching this video. Take care and goodbye.